It is with my distinct honor to present Dr. Brenda Wong.
Thank you so much, Deborah, and everyone here for this very warm reception and kind words. It's always a wonderful opportunity to be out of clinic and be with families. It's always a different set of atmosphere, and it's like we're all in one family. And thank you so much for giving our team this opportunity to be here to share this little afternoon session on the care of the Duchenne patient. So it has been almost 6 months that we've been here. The clinic has been running since July, which is about 3 months or so. And I would like to thank the families in the Northeast, especially the JB Keys, Hope for Gas, and Charlie Swan, to come up with this idea with you guys and everybody in this part of the world to have the vision for a dedicated Duchenne program. So here we are, and it is really our pleasure to share very quickly an overview of what we feel are the needs, and we cannot include everything, but then we have a Q&A session that we would love to have that portion for you guys to ask questions on some of the topics that's not covered. And any questions that come up through the talks, if you just note them down, and then we'll have them at the end of Q&A rather than individual for individual speakers as we present. So for those of you who have been to clinic, this is a sign that we have. And it's been an awesome opening ceremony for July 11th with balloons, cookies, and everything. We do take cookies. Okay. And for this overview, I would like to just briefly run through what you're going to hear from us. I would just hope to be on time with 10 minutes or so of a natural history. Remember, this is the Futures meeting, and to know what the future is, it's always good to reflect on the past, what has been accomplished, what has been achieved, and what's more to come, and what we can turn around into even a better future. So basically, I would also touch a little bit on current management in terms of steroids, because this is a difficult decision for families. To make a lifelong commitment to steroid therapy is tough, and to understand the rationale a little bit. So I'll cover a little bit of that, but a lot of it will be my team, wonderful colleagues at UMass who have come together to form this band of doctors, of Duchenne doctors. Dr. Michael Fahey, you want to stand up, Mike, for our cardiac care. Dr. Ted Kramer for pulmonologist, and our pulmonary nurse practitioner, Emily Young. And then we have Dr. Penny Feldman, our pediatric endocrinologist, integral member of the team. And of course, you guys all know Courtney, who's going to cover the big topic of constipation. I didn't want to put it there for an after lunch kind of thing, but nutrition, we have Jen Hall. You are what you eat, and that's really important. And then, of course, to round it off, just some of the tips with regards to equipment and PT issues. And then really the Q&A session, all right? I think everybody in this room knows what Duchenne is. I will not spend time on it, but really for us as a neuromuscular specialist and for families, the first decade is really a lot to do with the motor function. And basically, I would just run through the natural history real quick to just reflect upon how much has been accomplished over the years and how much more we look forward to. So this is in the 1950s, and you can see that, that's the progression for Duchenne's to the end stage of being malnourished, scoliosis, and contractures. It's a nice thing that we don't see that anymore, but we still see contractures. The malnourishment, I think, is on the opposite, because we tend to see obesity even at that stage. So basically, that was what it was in the 50s till the 60s came about, when you can have interventions for orthotics to improve the function from sitting to standing, standing to walking. So, the kid that is not able to stand, if we're able to correct that with the alignment, you can stand, and the next functional level we look forward to would really be walking, and then at that time, you would have like walking braces. So then you have the change from the motor function where you have loss of ambulation without steroids between this stage of 8 to about 12 to an improved age of a mean of 14, and then you're going to push all your other milestones back, and you have like ventilatory needs like being deferred a little bit, and then the cardiac is independent, so it's still around the 20s. But upper extremity function and all, again, you push it back. And that has been accomplished with contemporary steroids, with the better management of pulmonary care, with technology, and also with cardiac care. So you can see with also scoliosis surgery, we are now like in this era where you have pushed the age of loss of ambulation later to the mid-teens, pulmonary function way back down to the late teens. Cardiac function is independent of the motor function, so it may still kind of occur in the 20s. However, we're now pushing survival to the 30s, and so the next era will be, to just push it longer to make it a chronic disease and not a terminal disorder, okay? And I thought I'd just round up by saying that this is what we aim for, the 30s. This young man just turned 35 last week. And what has brought him there is he was diagnosed as Duchenne's by Dr. Mendel, enrolled in his deflazacort trial when he was 9 or 10. He lost ambulation at 13. But I would say he's probably more of the Duchenne spectrum of the typical and the milder and the more severe. I said maybe the milder end, but still, nevertheless, you can see that he is a guy who actually taught me how to overcome the side effects of steroids. It's from him that I learned that he can tolerate daily deflazacort, 52.5 milligrams, which is about 40 to 45 milligrams of prednisone a day. He started deflazacort at age 9, 10 in the trial. After 5 years, he was on a high dose, 1.2 mg per kg arm. After 5 years, it was 52.5 from age 15 to 35. That makes it 20 years of 52.5. So it looks like we're steroid dependent for him. But in the overall picture, we're able to manage his weight. We're able to manage his endocrine issues. And what we've discovered, the changing natural history, is that once you see a lot of progression, the first, second decade, 10 to 20, the second decade, and then much slower at the 20s. But after the late 20s, if they're stable, he actually, it's one of those that, you look at all these numbers here, that's his cough peak flow. And this is his MIPS and MAPS for strength for his respiratory muscles. And this is the forced vital capacity. It's kind of relatively stable over the years. So, and I'm starting to see that in the older kids too, for those on steroids, of course, that it's nice to see that we don't keep seeing that horrible progression after the 20s. It's like if you can keep them that good up till then, we are kind of like just in a stable phase. There's lots to be learned about the older 20s and 30s, but it gives us hope that we can actually be rather stable like at this stage. So he has also overcome a lot of side effects of the osteoporosis with good management of his bone health and his pubertal delays. And so he drives a hand-controlled car to work. He works 25 hours a week and as an IT webmaster. And he says that if I've got to do it all over again with steroids, I would. So I think he has taught us that if we are diligent about working on our side effects with our colleagues, with endocrine and all, we can overcome a lot of side effects. So that I see a lot of fear in a lot of parents, the newly diagnosed parents, in that decision to start steroids. It's the most difficult step I can see. So this is something that we look forward to. And then with all the advent of emerging therapeutics, we are going to expect, again, changing natural history. So we have collected like the natural history of our cohort on steroids. What we're looking forward for the next registry really is how the new drugs that's coming on the market, that's been approved, and all our clinical trial drugs, if you look at those patients' trajectories, whether that's any different. So I think we have still got a lot to learn, but certainly that is the changing natural history that's forever changing. It's a dynamic process, and we really are confident that we, as I was saying just now at lunchtime, probably I'll be retiring in 10 years because the patients will be doing so well. We don't need a clinic anymore, right? So basically, the next one is current management. And to me, I think I love this talk that I heard from Professor Rosenbaum from Canada when he came to UMass to talk about, the F words in childhood disability. And I thought this is applicable to every chronic disorder, whether it's cerebral palsy, autistic spectrum disorder, or DMD for that matter. So as a team of providers, our goals will be to make sure that 1, 2, 3, 4, 5, 6, the 5 F words are really in our agenda for us to review with parents what our goals are. So basically, the fitness of it, right? We want to make sure all that the patient is fit, all the systems and everything else. And then we want to make sure that we have disabilities, we have impairments, we have dysfunction. It's our job to support, to give them function with all the technology that we have, all the equipment that we have. But our team's goal is not just this. We also want to make sure that the patient has got, as we were talking with Deborah earlier, the friends that Hawken has, the 13 friends that stay with him, that take good care of him and have that kind of relationship that enable us and the patient to really be positive in the midst of all challenges of motor disabilities. And we want to make sure that the family support is there. The family has got optimal quality of life. And we want fun, so they need fun as well. So just to make sure that all these aspects as parents, as caregivers, we have to check this off. And last but not least, this is the future. The future, they have a future, and that's where you are here today, where there are trials, there are updates, and the new guidelines for cares and so on. So just remember, this is our goal. And in order to accomplish that, really, it will be entailing like a care team that is very team-based. It's not an individual kind of provider that just interacts with the family, but we talk, we coordinate care with all services. The care coordinator is key. And we collaborate. I think here is collaborative care. Like, for example, we just had a kidney dysfunction, and then you that's related to the heart, and then you have got like the testing for the renal function that in the context of a Duchenne with poor muscle mass is something else that we have to talk to our GI colleagues about the liver enzymes in relation to Duchenne's patients, and we want to talk to our renal physicians with regards to the urine creatinine ratios that's kind of out of whack for our Duchenne's. So a lot of collaborative care is needed. Communication is key, whether this day and age with emails, with phone calls, and so on, my chart and so on, and also to ensure that we kind of provide continuity care over the care cycle from the young child to the adolescent, to the young adult, to the older adult, 30s, 40s. So the care team needs have to evolve with that as well. So in summary then, I would say that I would kind of just cover the steroids real quick for the strength part. I'm not going to go into PT and all, which you will have tomorrow. And growth and nutrition, we have endocrinologists and a nutritionist to cover that topic. Cardiopulmonary, I say they're married, so they're all sitting there. The cardiac and pulmonary team, endocrine dysfunction, that we talk a lot about the risk of adrenal insufficiency with steroids, the GI, and then psychosocial I'm not covering because there's a topic tomorrow as well. And then, of course, the carrier moms, the families, and so on. So in essence, this is what the overall care would look like. So in terms of treatment though, here we have treatment strategies for Duchenne's, whether we produce dystrophin right now. We have exon 51 skipping surreptase eteplirsen. We have attenurin that is marketed in Europe for nonsense mutation to produce dystrophin, the missing protein. And then this whole chunk of inflammatory response is important. TGF beta pathway, a lot of drugs that's in trials right now with our patients, and the one that is standard of care, as you know, is steroids. And of course, that is the muscle membrane. There's some drugs in trials coming up that they will stabilize this and improve muscle repair and regeneration, other trials as well. But I would only kind of cover this right now. So the questions that we are kind of used to is which steroids, why do we use steroids, how does it work, how is it prescribed, how do we start and stop, how do we mitigate the side effects, and what's the outcome. So these are the questions, but I don't think we have time to go through all that. We will just kind of have a one-to-one chat if you've got specific questions for those, but I will just run through some of the highlights here. It's thought to work through membrane stabilization, influx, calcium influx inhibition, and immunosuppression with the TGF beta pathway. So the less inflammation you have, the less damage, the less fibrosis. So for steroids, less inflammation, less loss of muscle. When you're 15, you've got a little bit more muscle than a 15-year-old without muscles, and so on. So we're buying time, but it's not a curative treatment that will address the problem of dystrophin deficiency. And why? This is just a slide to show you the rationale from way back, the CIDD trials, that it's double-blind placebo control. Here is natural history. Here's with steroids, okay? And then the different doses. And how is that prescribed? You can have prednisone, you can have deflazacort. The dose that we recommend is from experience, really. It's not from PK studies or the lab. And then whether we're doing daily or intermittent, that's also a lot of debate about that. And we always discuss that in clinic with parents for them to make that informed decision. And when do we start? I think here we want to start like as soon as you're confident this is Duchenne's, with a child who is able to cooperate with testing, but also height-wise, you're not going to start a 1-year-old or a 2-year-old that's going to be that short. But you see, height grows by 6 centimeters a year for the first few years. So by the time most of them are diagnosed at 4, 3.5, 4 to 5, they are pretty much of the height. And depending on their height, you can always review what dose to start with as well. This is, do we stop? I've seen patients that have stopped, and unfortunately, when they stopped, they lose all that they have gained to go back to where they would be without steroids. So I think, not doing steroids, you're here. You do steroids, you're here. Once you stop steroids, you go back there. So it's not that steroids will make you worse. It's just that you just revert back to where you were without steroids, okay? And so you still have arms, you still got breathing muscles. So we do not stop steroids when you stop walking. Your muscles, you got muscles above the hip. It just shows that the median age of loss of ambulation without steroids is about 10. With steroids overall is about 14. And this is daily deflazacort is about 14. The red one is 10 high dose weekend. Weekend is about 10 point something. The yellow is intermittent, 10 days on, 10 days off. This is daily PrEP, I think. So this is clustering about 11.9. So daily, deflazacort 14, and this one is around here, okay? So this real quick, this is like the mean age of loss. Okay, for upper extremity function, what's important? To raise your arms above here, to bring to here, and to do this. So basically for this one, mean age of loss of ambulation about, like here is about, without steroids is about 10, with steroids about 15. So you are without, so you can do this. And then this one is like up to here, all right? So it's like 15 without steroids and about 20 with steroids. And this is your hand function. It's like in the 20s. So you can see that with steroids, your upper extremity function is different. So you shouldn't stop. So real quick, other benefits of steroids, we also pulmonary function, cardiac function, and the spine. And I'm on time. Okay, just real quick, just the emerging care needs I hadn't had time to cover, but bone health is one area where there's no consensus, and we're just talking with our endocrinologists, like we want to be proactive, we don't want to be reactive. We still got an area of discussion to go through that, but we've got some data that we gleaned a little bit from the past 13 years of use of bone medications that we can review that will help inform us and guide us. Psychosocial health, as we talk, is important, and also a lot of it will be with the neurocognitive aspects of it. That's another big topic that is still kind of like emerging. And then the fat embolism syndrome, but most families are pretty aware of the risk. But just one highlight for this is we tend to see this a lot of fat embolism cases is a lot of kids as obese. So the older kids who got lots of like 50% body fat. So I think that kind of what jolt us into like working on your diet and not putting on weight with a lot of sub-Q fat, right? And renal, it's cardiorenal syndrome. We kind of picked up one patient that may be along those lines, and then kidney stones. We have never really had talks about that, but certainly it is a problem. And then, of course, last but not least, care teams for our adult DMD patients that we're trying to work into, since adult neurologists and neuromuscular docs have not seen patients who are like 30 over years old or 20 over years old. So this is the emerging kind of need that really is to be worked out. So with this, I thank you for your attention, and I would love to hand this to Dr. Fahey, our cardiologist.
So hello, everyone. My name is Mike Fahey. I'm a division chief for Peds Cardiology at UMass. I've met many families. I'd first like to thank you for having me today. I also like to thank Dr. Wong and Courtney and the whole team for allowing me to be part of the team. It's been a real privilege to work with you and your boys. The multidisciplinary clinic at UMass has just been phenomenal, and I'm very proud and happy to be part of it. So you're going to hear, for those of you who've met me in clinic, this is going to be a little bit of a review because I tend to kind of go over some of this stuff when I see my patients, because I always think it's a good idea to kind of understand what the rationale is behind what we're doing, so that when things change, you understand why things change. And I'll be talking about that a little bit later on in this probably 10-minute or so discussion. So as you're aware, Duchenne's muscular dystrophy is a muscle wasting disease. We'll talk about what dystrophin is and kind of where it lives in the cell and what it does. But of course, the heart is just solid muscle, right? So when dystrophin here, which is this little purple molecule here, it's a scaffolding protein that's in all muscle cells, and it helps to link the contractile part of the cell. These are the actin and myosin filaments that do all the contracting. Dystrophin is one of the molecules that helps to kind of bridge the gap between the contractile parts of the cell and the cell membrane, so that the whole cell can contract in an organized kind of way. It also has other functions, but that's the main one, is that it's a scaffolding protein. And so when you have mutations in the dystrophin protein, you end up getting problems with coupling between the shortening elements of the cell and the cell membrane, and that causes a weakening of the muscle. And also, because of some other functions of dystrophin, it also ends up leading to cell damage and ultimate cell death in some cases. So the heart is a pump made of striated muscle. Because Duchenne's muscular dystrophy affects all striated muscles, the heart is obviously a main risk in kids with Duchenne's. This is a busy slide. We're going to focus on kind of the bottom quarter or so of this figure. As I mentioned before, you start with this abnormal dystrophin protein, and because of the abnormalities in the protein and because it doesn't function the way that it should, you end up getting damage to cells, and the cells can ultimately die. Whenever you have cells that are breaking up and not functioning any longer, your body goes in to kind of clean up the process, and we call that process inflammation. And the inflammation, unfortunately, a lot of times goes a little bit haywire, and it ends up causing a lot of collateral damage. Steroids, as Dr. Wong was just talking about, is one way to kind of mitigate that inflammatory response, and has been a real boon in terms of preserving particularly skeletal muscle strength. And what ends up happening with respect to heart muscle is that when you get that inflammatory response and damage to heart muscle cells, it kind of leads to three main findings. That is ventricular dilation, so the ventricle is the pumping chambers of the heart. We're mostly concerned about the left ventricle, which is the ventricle that's pumping blood out to the body. Ventricular dilation would be a stretching out of that heart muscle, and I'll explain why stretching out of that heart muscle is something that we're not happy about, and we're going to try to deal with. We also look for ventricular dysfunction, so the heart's not squeezing the way that it should. And the third thing that we're going to look for is ventricular fibrosis, and I'll describe that process in a minute. So to go over those kind of three things that we're going to be paying attention to with respect to heart muscle in kids with Duchenne's, this is a slide straight out of my lecture to first-year medical students when I teach them about cardiovascular physiology in their first year. We learn about kind of how that left ventricle works. You can think of the left ventricle as just kind of a bullet-shaped balloon of muscle. And when we think about the force against which that muscle has to squeeze, most people think about blood pressure. The higher your blood pressure, the more forcefully the heart has to squeeze in order to overcome that pressure. But it's a little bit more complicated than that, not much more complicated. So internal pressure exerts this force that the heart has to squeeze against. But the other thing that ends up contributing to the force against which the heart has to squeeze is the size of the balloon. So if you think about taking a balloon and blowing it, you're blowing it up, there's usually this little nub at the end, right, that stays kind of deflated. What ends up happening is that if you blow up that balloon enough, the balloon will eventually burst. The internal pressure of the balloon actually doesn't change a whole lot as you inflate it. Once you kind of get it to this stage, as you put more air into it, it just distends, but the pressure doesn't build up all that much, actually. What ends up happening, though, is that because the balloon is getting bigger and bigger, the tension in the wall of the balloon ends up increasing, actually in a linear kind of way, directly related to how big the balloon is. And what ends up happening is that once the balloon gets big enough, the tension in the wall overcomes the inherent strength of the rubber, and that's when the balloon bursts. So most people think about afterload, or the force against which the heart has to squeeze, as pressure, but it also has to do with the size of the heart as well, and that's why we pay attention to that. The third thing that I mentioned before was fibrosis. That's the other thing that we're kind of looking for when we do our imaging modalities. These are a few slides from a cardiac MRI, and you'll hear us use this term late gadolinium enhancement. If any of your boys have had a cardiac MRI, you're aware that an IV is placed and they receive a contrast agent called gadolinium. And gadolinium helps light up heart muscle when we do a cardiac MRI, but then that contrast agent is washed out of healthy muscle. What will end up happening, though, if any of that muscle has been replaced by fibrosis through that inflammatory process that I mentioned before, the contrast will kind of linger behind because the muscle isn't perfectly healthy. And so when we look here, here's an example of the left ventricle, that bullet-shaped structure that I said before. Healthy muscle it should be kind of dark, like a black color like this. But you can see here, and this, by the way, is the right ventricle over here, all these little red arrows are pointing to areas where that gadolinium, that bright contrast agent, has not washed out of the muscle. It lingers behind. Here's that bullet-shaped structure, that left ventricle cut in a short axis, so it looks like a circle. And again, you can see this kind of, that bright gadolinium, late gadolinium enhancement. Here's healthy muscle here, and there's the muscle that's been affected by fibrosis. And we actually, when we see patients who have cardiac MRIs and they start to exhibit evidence of fibrosis, I think a lot of people panic a little bit. Oh my gosh, we're seeing this fibrosis. Is that a problem? The evolution of fibrosis in the heart muscle is a natural process that's part of Duchenne's muscular dystrophy. And seeing a little bit of fibrosis, we expect to see that at some point. It's not by any means the end of the world. We have plenty of people who have plenty of fibrosis, and yet the dimensions of their heart are normal and the heart function is normal. So just seeing fibrosis doesn't necessarily mean that you're going to develop dysfunction. Now, when you develop enough fibrosis, that does correlate with areas of the heart that don't squeeze as well. But when we first see evidence of fibrosis, it's no reason to panic. We're going to expect to see it at some time, and the main reason we care about it is because we're now aware of the fact that when you start to see evidence of that fibrosis, it seems that the addition of certain medicines that I'm going to talk about in a minute seem to have a protective effect. So we use the evolution of that fibrosis as kind of a flag or a trigger for us to say, oh, okay, this process is starting, now let's do something about it. Once these processes start, fibrosis, any element of dysfunction or any inherent weakening of the heart muscle, the heart undergoes a process of what we call remodeling. So remodeling is your heart trying to do its best to compensate for the inherent weakness of the muscle. And what happens is several hormones that float around in our body, including adrenaline, angiotensin II, aldosterone, have effects on heart muscle that end up changing its shape and changing the way that it squeezes. As it turns out, what ends up happening is that you get a progressive stretching out of the heart muscle. If we were to just leave the body alone and let it do what it's going to do, you would end up with a heart that looks like this, kind of stretched out and dilated. And I just told you that a stretched out, dilated heart is a heart that's under stress. It's under increased stress. So we actually want to interrupt that process. And the way that we do that is by actually counteracting your body's natural response, because the way that humans evolved, we weren't. When you have a challenge to your heart, your body's just interested in getting to the next water hole or kind of staying alive in the short term. It's not thinking about the consequences of those changes 10, 20, 30 years down the road. And so in other words, our natural remodeling process is a maladaptive one. So what we try to do is we actually prevent the body from doing what it wants to do in the interest of maintaining a more normal heart size and thickness. And as Dr. Wong pointed out, we're learning about this all the time. I think the biggest probably change in the past 20 or so years is the institution of some of these medical therapies that I'll be talking about earlier and earlier. And I've met several of the families in this room. I've talked to a lot of you about starting, for example, ACE inhibitors in kids, once they hit 10 years of age or so. That's relatively new stuff. It's not stuff that's been done for decades and decades. So we're learning more stuff about this all the time. We try to make our recommendations based on the best data available. The American Heart Association came out with a new set of recent guidelines for treatment of neuromuscular diseases, including Duchenne's muscular dystrophy, just last year. So this is based on the best data that we have available to us. And so when you meet us in clinic and we talk about heart health, this is based on the best stuff that we know. And things might change in 5 or 10 years. And I hope it does. I hope it does for the better. We're learning more and more about Duchenne's and how to help the heart in Duchenne's muscular dystrophy patients all the time. So what's in our toolbox? We have 3 main tools. And again, these 3, notice the language here, angiotensin converting enzyme inhibitors, aldosterone antagonists, beta blockers. So our 3 kind of main tools in our toolbox are aiming to keep our body from doing what it wants to do, because again, our adaptive mechanisms are maladaptive. But these are the 3 kind of main things that we have, and you folks are probably familiar with some of the names of these medicines up here. Again, we're looking to prevent the remodeling process. The way that ACE inhibitors work is, again, angiotensin converting enzyme inhibitors. They prevent your body from producing a hormone called angiotensin II, which tends to boost blood pressure and has, again, bad remodeling properties on the heart. We probably have the most data about ACE inhibitors. And these are the medicines that we think of as probably being the most helpful in terms of reducing afterload, reducing that stress on the heart, and preventing that maladaptive remodeling that I was just mentioning. Another class of medicines that are very similar to ACE inhibitors are angiotensin receptor blockers. So while ACE inhibitors prevent angiotensin from being formed, angiotensin receptor blockers, for example, losartan, those just block the receptor where angiotensin communicates with the cell. So we think of losartan, angiotensin receptor blockers, being very similar in terms of their quality to ACE inhibitors. And some people will, for example, if you have a bad side effect from an ACE inhibitor, you'll go on to an ARB, an angiotensin receptor blocker, instead. Aldosterone, that's another hormone in our body that has these bad effects on the heart in the long term. And so aldosterone antagonists are another class of medicines that we add. And again, this is based on the most recent data that we have. It seems like adding an aldosterone antagonist, when you see that first hint of fibrosis, that late gadolinium enhancement on cardiac MRI, it appears that folks who are on aldosterone antagonists at that point, they seem to yield some long-term benefit in terms of maintenance of heart health. And then finally, beta blockers. You can think of beta blockers as kind of anti-adrenaline, adrenaline being another bad hormone in terms of maintaining heart health. Whenever we start to see evidence of ventricular dysfunction, where the squeeze of the heart isn't normal, that's when we usually introduce a beta blocker. And we have very good data to show that beta blockers are definitely something that you want to be on if you have diminished squeeze, diminished heart function. We haven't been able to prove that they're helpful in a preventative kind of way. So people have looked at, well, why don't you just start beta blockers on everybody just right off the bat? It doesn't seem to have a protective effect, but once you develop a little bit of dysfunction, they're definitely helpful medicines to be on. So what's next? Our therapies, as you probably noticed, are for the most part reactive. We're kind of waiting for something to happen, and then we're getting started with the medicines. I think starting things like ACE inhibitors at a young age before any heart involvement is seen, that's kind of more of a proactive strategy, and I'm hopeful that as we learn more and more about Duchenne's, we'll have more proactive things that we can do. Our therapies intervene on normal physiology kind of after it's deranged, so it would be great if future medical therapy hopefully will intervene earlier on in the disease process before some of the damage occurs to the cells. And the other thing that we hope is we hope to identify other markers for kids who develop early heart dysfunction so that we can do a better job of jumping on top of the process and treating it appropriately. The example of finding fibrosis and starting spironolactone or eplerenone in those patients is a good example of, oh, this is a marker that we can use to try to identify kids who might actually benefit from other therapies. So I believe that really wraps up my part of the talk. My email address is down here. Feel free to email me with any questions that you have. And I believe that we're going to do a Q&A at the end, so I don't think I'm going to field any questions right now. And with that, I believe I'm going to pass things on to Emily. Is that right? Yeah? All right. Thank you.
All right, is the mic on? Okay, good. So I'm Emily. I'm the nurse practitioner on the pediatric pulmonary team at UMass Medical Center, and I was very excited when I heard that Dr. Wong was coming because I love airway clearance, and I'm very passionate about it, so I told Dr. Kramer that I wanted to be involved. In early childhood, we are watching from afar. We're not getting involved unless we're needed to be involved on the pulmonary team. But when there is a problem like a pneumonia or something's going on, we really believe strongly in making interventions fun. We use, with other pulmonary children, we're using pinwheels and we use positive pressure bubbles, blowing to really help move secretions in a controlled way and to really help prevent worsening of lung disease in early childhood. As the children start to age, we'll start seeing the boys be 1 to 2 times a year, starting around between age 5 and 8. They're able to cooperate with the testing, and we're able to start working with them more intensely for airway clearance teaching. We'll do 3 big tests starting around age 5 to 8. So the MIPS and the MEPS, the maximum inspiratory pressure and the maximum expiratory pressure, are a measure of the strength of the muscles on inspiration and expiration. You'll see that test being done. The pulmonary function testing is there's a lot of numbers that come out of that test, and it's applicable to many different diseases. In Duchenne's, we're looking mostly at the forced vital capacity, the FVC, and this reflects the total amount of air that you can exhale from your lungs after the deepest possible inhalation. So it's kind of like take a deep breath and blow it all out at once, and that measurement is your FVC. And then the last measurement that we're looking at is the cough peak flow, and this is the strength of the cough to clear your throat and airways. These are numbers, and they vary from visit to visit. If you do it one test and you repeat it, you'll get a different number. And we use these numbers as to help us make a decision. They're not final in what we do. The numbers will vary from visit to visit depending on the person doing the test, on the mood of the child doing the test. Certainly, if you're not feeling good, you're not going to give your best effort, and that's okay. We all have bad days. And then also from the machine, too. If there's, machines aren't perfect. So other aspects of pulmonary care, starting around age 5 to 8, we'll start lung exercises and lung stretching. Just like you're stretching the muscles, you're going to stretch the lungs. We do that with breath stacking. You can do breath stacking manually or with a one-way valve. And a one-way valve is just, you see a picture of it, it's just a simple little tube with a valve that you cannot exhale against it. It kind of locks the air in. So you would use it with a mouthpiece or a mask when you're doing your breath stacking exercise. A breath stacking is it's like blowing up a balloon. You're taking multiple inspiratory breaths, though, on top of each other. So each time you take a breath in, you hold it, and then you take another breath in and stuff it on top of the first breath, and you do that 3 or 4 times. After you exhale, you sort of feel a little stretched out, and you do 5 of those breaths, and you feel really stretched out. And I like to think of it as after you've swum a lot, when you're a little kid and you go to bed that night, and you just feel like your lungs felt all kind of stretched out. That's kind of what the sensation that we're going for with the kids. Some important considerations for doing these lung exercises is that it takes a lot of effort for the children to do it correctly or to get the best effort. So one thing I always recommend to families is to not do it last thing at night. You have so many things to do throughout the day caring, but if you put something that takes a lot of coordination and effort on at the end of the day, they're just too tired to give a good effort. So I usually recommend kind of moving it forward to an earlier time in the day, and a time that works best for the family. As a care provider, I think sometimes it's important to put on your coaching hat when you're helping coach your child through these exercises, because you don't want to fall into the, pushing them or criticizing, or you just want to just be supportive and give a good effort. So kind of stop what you're doing, take off your parent hat and put on your coach hat so that you can always be positive when you're help to coach through something that they need to give effort on. And make this a family affair. I was looking all the F's in chronic illness, and I think we hit this with the pulmonary care too. The child, sometimes I hear families say, oh, I keep that in the bedroom, or I keep that machine in the other room, and the child goes in the other room and does it by themselves. And I'd rather say, you know what, make it a part. Put it in the center of it. If the kitchen's the busiest place, then keep it in the kitchen so that everyone can be involved, coaching, helping, supporting. And then the other final thing about breath stacking is that it's also good for anxiety. You do these exercises and you're going to feel relaxed afterwards. So it's something that you can use as a relaxation exercise too. It doesn't have to be perfect effort in those circumstances, but it's gonna, it can be applicable in several different ways. So the other thing, I can't pitch breath stacking enough apparently, but it can be done anywhere. And I'll tell families with other chronic illnesses, you do it in the back of the car when you're driving to all your different appointments. Every red light, you have to do a breath stacking exercise. When you're waiting in a doctor's office and you're getting bored, you can get it out of the way too. So it doesn't need a lot of equipment. Now, the one equipment that families ask us the most about is the cough assist machine, and that's often the first piece of equipment that comes in the house. We use the cough assist machine for 2 different things, and I'll talk about the hyperinflation mode first. So hyperinflation takes the place of breath stacking. It's done once a day or twice a day, and you're going to do about 5 breaths and 5 cycles of 5 breaths. And you're going to take a short pause between breaths to get a little rest, and then you're going to take a longer pause between the cycles. It changes. Once the home care company comes out to kind of teach you how to use, or we teach you how to use the cough assist machine, you're going to start with kind of an introductory pressure. And I think that we should be aware that these pressures can change as the child gets more comfortable with using the machine. We might be able to increase the pressure a little bit, or as the child grows, the lungs also will grow a bit, and the pressures can go up. So these pressures can be variable. Then the other mode that the cough assist mode machine is known for is the cough assist mode. And this is the classic. The old machines only had the cough assist mode, and we are kind of teaching families how to do the positive pressure hyperinflation breaths from that one setting. But the cough assist mode, it pushes breaths in with positive pressure, and then it sucks the breath out with a similar negative pressure. So push in, suck out. it's a really interesting sensation, and it's not something that is comfortable when you first start doing it. You'll do about same thing as this breath stacking. You'll do 5 breaths in and out with a short pause in between, and then 5 cycles of breaths. Important considerations when you're doing the cough assist machine in this mode is the seal is very important. And I also say it's important for hyperinflation as well. Oftentimes, it's best to have the caregiver hold the seal in place, not the child. And then the child, also you're thinking about the goal is to move mucus out, and the best way to move something is up a straight line, so posture is very important. Sitting up is really good. You gotta get that mucus up and out. And then once again, coaching for participation is really important because this does not feel good when you first start doing it. Encouraging them to inhale when the machine inhales so that it's more natural, and then to kind of try to force a cough when the machine is trying to suck it out. And I think that's the hardest thing for the kids to learn. I will say from older patients with various diseases that use the cough assist, they will say there's an aha moment when they finally move a big piece of congestion out, and they're like, now I understand what this machine is about, and now I'm going to use it because I know what it can do. And it doesn't happen when the first or second year that you have it. It takes a lot of practice. So I will recommend practice when the child is not sick for best results, maybe once a week, just so you're like not rough, because you never know when a bad cold is going to hit. As I wake up with a sore throat today. And then during illnesses, you want to do it once or twice a day, or if your kid had that aha moment, they can use it as much as they want, every 3 hours, whatever they want to make them feel better. So finally, we're going to talk quickly about the vaccines. We do recommend that a yearly flu vaccine is very important. Even though you could get a different flu, you're being protected from the 3 or 4 most severe flus that are predicted to be out in the community this year. So it's very important to get it. And then the pneumonia vaccines, the PCV13 up to 2 years of age, and then the PPSV 23 after completion of the PCV13. So with that, I'm going to pass it on to Dr. Kramer, who's going to talk about sleep and machines.
I'm going to echo what others have said. It's been great being a part of this team that Dr. Wong has started at UMass, and the point of it being a team, I think, is the most important part, because everybody that is a part of this team really, I think, feels fortunate to be working with your children and you guys as well. So with that, I'm going to move forward with this and focus more on the sleep part. I do work with Emily. Actually, we both do pulmonary and sleep as well, so it's not that she does pulmonary, I do sleep. It's a combination of both for each of us. So I'm going to take a moment and talk first about obstructive sleep apnea as well as then hypoventilation. And this is, it's not unique to children and individuals with Duchenne's. This is something that can be in anybody, and then other medical conditions as well. But I think of it almost as a bimodal distribution when I'm thinking about sleep apnea and hypoventilation when I'm considering a child or individual with Duchenne's. The sleep apnea part, the obstructive piece, is usually something that we might think about first in the first 5 to 10 years of life or so. And then this hypoventilation piece that it's more of a later on type of respiratory concern that we consider. So not everybody in the first 5 to 10 years is going to develop the obstructive sleep apnea, but there are some, and this can be for any child, whether you have Duchenne's or not. And the risk factors are somewhat similar as well. I mean, the most common risk factor that I think about for sleep apnea or obstructive sleep apnea is having large tonsils and adenoids. That is the biggest reason for that. And then we can see that in any child. And so it's something that we look for. We ask about snoring, and we're questioning about disrupted sleep and sleepiness during the day, and even other daytime behavioral concerns that can present with that. And then the other piece of it can be weight gain. And thinking about steroid treatment, that is a potential side effect is the potential for weight gain, which can then lead to changes in the way the head and the neck may develop, and fattiness in and around the airway that can make you have a little bit more obstruction and more sleep apnea concerns. You can see airway collapse, and then there's just some individuals who have a small airway for different reasons. For example, you'll see some people who have a little bit of a smaller chin, and it's not unique to Duchenne's, it's just something that anybody can potentially have. So those are the risk factors for sleep apnea, and I'm going to come to treatment here in a little bit. The bimodal piece is then going into the adolescent to adult years. You get into more of a hypoventilation risk. This is more related to the muscle weakness that may occur with time, considering it's often, it coincides with the ambulation piece of one's care. As ambulation is becoming more of a concern, we typically see more respiratory muscle weakness that then makes them a little bit more at risk for reductions in the way breathing is during sleep. We all breathe at a little bit of a lower lung volume when we sleep, and then during specific stages of sleep, REM sleep, rapid eye movement sleep, when we're dreaming, our muscles are even more relaxed and in almost a paralyzed state. We're more likely to have some concerns that we're not getting in enough air. And then if you have muscle weakness on top of it, that is a bigger concern. So, and this often coincides with decreases in pulmonary function. So some of the things that Emily was talking about, we will be doing lung function tests in the clinic that also help us to think about, is this person at a risk for having the hypoventilation based on lower lung function that may come with time. And so those are things that we keep an eye on. When we have concerns about sleep apnea or hypoventilation, it leads to this, a sleep study. And this is what your child's going to look like when they're coming in for a sleep study. There's lots of little wires, as you can see, but there's always a smiling face who's helping to make sure that the process goes smoothly. And there's always a parent with the child at the same time. So we talk about this in clinic. There's lots of wires, nothing hurts. They stick to your head, you get a little bit of gooey stuff in your hair, and then we try to get it out the next day with you, or have you work hard to get it out. But in the end, all of this stuff gives us a chance to monitor your breathing, your oxygen levels, your sleep stages with the EEG wires, and so we really get a good sense of your risk for sleep apnea as well as hypoventilation based on oxygen levels and carbon dioxide levels that we monitor throughout the night. And so treatment really depends upon what we find. So in the younger ages, if you have more of an obstructive sleep apnea, and if you have big tonsils and adenoids, surgery is going to likely be the treatment. Sometimes we go down the path of nasal steroids or allergy-based therapies if it's more of an allergy-based symptom that you're having. Sometimes just trying to keep them off their back can be helpful. And then, I should have put in here, I just realized I forgot to put in, weight can be something that's really important to monitor as well as to address if there are concerns with being overweight, having nutrition help with that particular piece of it. And then CPAP is a treatment for obstructive sleep apnea. In an individual, a child with Duchenne's, we usually go down the path of BiPAP. So the difference between CPAP is a constant pressure of air that helps to just distend the airway. BiPAP actually has that low constant level of air, but every time you take a breath in, it supports the breath with more pressure. So you're getting that constant pressure that kind of keeps the airway open, and then every time you take a breath, it's giving you more breath, more air, and then that helps you to get more oxygen in as well as to get the carbon dioxide out. And so when we're thinking about the individual who has more of the muscle weakness concerns and the need for BiPAP, this is what we're really thinking that we're going to be doing, is using BiPAP with a mask. And I'm going to just move on to the next one, because if we go to BiPAP, this is what we're considering is, what is it to do, what do we need to do to help support them while they're sleeping at night? And so not everybody likes the idea of wearing a mask, and I can totally appreciate the point of that. You can see that there's lots of different masks, and this is only a small number of them. There's many more beyond this. We have full face masks that go over the entire face. We have some that are a little bit smaller full face masks, but still quite large. more often than not, we're really talking nasal masks. And to be honest, probably the safer approach is the nasal mask, just from the standpoint not covering the mouth. If you happen to be sick and you have an episode of vomiting, you want to be able to have that come out your mouth. So having a nasal mask is typically considered a bit of a safer approach, and likely what we're going to use for most of these children and young adults and the like. So you can actually do this during the day. These are twin brothers. I'm going to guess maybe some of you have actually seen or heard of these individuals in Australia. They're now, I think, in their 30s, who are using basically BiPAP throughout the entire day and night to help them with supporting their breathing. So we typically think of it as a nighttime thing, but it can actually be used as a daytime way to support breathing if necessary. So this is bringing it all together, both from the standpoint of Emily's piece with the pulmonary as well as the sleep. The newest guidelines that have just come out go over specifically, thinking about one stage of ambulation, the breathing assessments that we do with lung function tests, a sleep study that may or may not be needed early on versus later on, and then the interventions that we do, including the vaccines and the different types of cough assists and one-way valves, and then eventually going into, as you're getting older, the potential for BiPAP use. So just kind of a quick little summary of that. I always like to talk about normal sleep. This is always very simple things, but I'm going to encourage that your adolescent, your young children are getting, 10, 11, 9 hours of sleep, depending upon their age. Your adolescents, up to 8.5 to 9 hours, I think is really important. And it is often forgotten that a 16, 17-year-old really needs more sleep than us as adults. And then sleep habits and hygiene. We all could use this, even us as adults, I think. Beware of electronics. I encourage keeping these things out of the bedroom. If you're on your cell phone at 11 o'clock or 12 o'clock texting someone, that means that there's someone on the other end of that cell phone doing the same thing. And so sleep is not happening, unfortunately, when those things are going on. So I encourage, be aware of your electronics, keep them out of the bedroom, I think is really the best. Avoiding caffeine in the evening hours, alcohol as well, and then, age-appropriate schedules, thinking about, your bedroom, timing, weekdays to weekends, not being up till midnight, 1, 2 in the morning on the weekend, sleeping till noon, because when you do that, it very easily messes up your ability to then, go to bed at a normal hour on the weekdays and getting up for school or work or whatever it should be. And, I think we should all make sleep a priority. It's a really important thing. So, with that, we'll move on.